Let me start another important topic in obstetrics, that is diabetes in pregnancy. You need to know certain things here. And it is a topic which is very importantly related to the neonatology also. What are the effects of diabetes in pregnancy regarding the baby? What happens after the baby is born? What happens when the baby is still developing inside the uterus? All these things we are going to cover. Now, diabetes is one of the most common medical complications of pregnancy. There's no doubt about it. And uh, let me ask you, what is diabetes first? What is diabetes mellitus? The general, general type of definition. Anybody?
Increase sugar level more than normal.
Sir, high
Hypoglycemic
blood sugar
condition.
level, hypoglycemic level should be, you can say it more now.
Okay. So you're right. Okay. So that's the way you should answer, because the topic was not taught to you. The topic was not taught to you. It will be taught in endocrinology in case of internal medicine when you move on to the 7th semester, because we are teaching endocrine during that semester. So never mind. Let me explain it right here. Diabetes mellitus is a syndrome. It is a collection of symptoms and signs where there is persistent hyperglycemia occurring as a result of absolute or relative deficiency of insulin. Always correlate insulin along with diabetes mellitus definition, because insulin is related there. This is a disease which is associated with insulin, either absolute deficiency, okay, or relative deficiency. Absolute means there is no insulin at all, like in type 1 diabetes. There's no insulin production or secretion. And a relative, uh, deficiency means there are two aspects now. One, insulin is still getting secreted from the beta cells, but the amount is not enough. And more important than that, it is getting resistant in the receptor level. The insulin is there, but that insulin is not acting properly because of receptor resistance. So this is known as diabetes mellitus. Now let's come to the topic. We are talking about diabetes mellitus during pregnancy. So if a lady develops diabetes during pregnancy, then this is known as gestational diabetes. She should not have diabetes before. She should be normal. But during this pregnancy, if diabetes mellitus is diagnosed, then we call it gestational diabetes. Whereas if she is already diabetic, on top of that she is getting pregnant, we call it chronic diabetes. Okay, chronic diabetes, or maybe overt diabetes. So these are the different terms. I'm sure you are quite clear. So let's move further. So patients can be separated into those who were known to have diabetes before the pregnancy. They are called known as overt diabetes or chronic diabetes. Both terms are correct. And those diagnosed during pregnancy are called gestational diabetic. So it is estimated that 90% of all pregnancies complicated by diabetes are due to gestational one. And this is a good fact, because most of this gestational diabetes will disappear after the birth of the baby, and they'll come back to the normal life. But some unfortunate ladies continue to have hyperglycemia even after the birth of the baby. Let's move on. Now, all of you please focus on this slide. The same thing which I was talking is repeated here. Diabetes in pregnancy are divided into two types. Pre-existing diabetes, also known as overt diabetes mellitus or chronic diabetes mellitus, whereas the diabetes which is developed right now during this pregnancy is known as gestational diabetes. Now, this overt or chronic diabetes can be of two types, type 1 and type 2. Type 1 is also known as insulin-dependent diabetes mellitus, IDDM, insulin-dependent diabetes mellitus, and this is non-insulin dependent diabetes mellitus, NIDDM. Though this NIDDM is a misnomer, This is a wrong term actually. The better terms are type 1 and type 2 diabetes. Now, why is this a wrong term? Because even type 2 diabetic people or patient, they need insulin later on. They need insulin when the disease is very severe or uncontrollable because of other oral, hypoglycemic agent. They need insulin. So how can we say this is non-insulin dependent diabetes, right? So this is a wrong term. But still, in so many textbooks, this term is also very commonly used. Now, let's talk a little bit about pre-existing diabetes or overt diabetes mellitus. This slide is distinguishing type 1 diabetes from the type 2 diabetes. Okay, so this is a bit of extra knowledge for you. Just take it like that for the time being. Now, see here. So these are the characteristic feature which we are going to talk, and what happens related to this feature in type 1 and type 2 diabetes. Let's distinguish each other. Type 1 diabetes is autoimmune disease. Remember this. This is autoimmune disease. There is insulitis development in type 1 diabetes. As a result of this, our own immune system, okay, destroy the beta cells which are present in islet of Langerhans. So there will be no secretion of insulin. And we call it, okay, a type of autoimmunity or autoimmune mechanism. And the genetic locus which is responsible for that autoimmunity develop on chromosome number 6. Chromosome number 6. Okay. Now this, if you remember, this is the same chromosome which is responsible for HLA gene also, HLA. So it is associated with HLA, DQ, DR3 like that. Whereas a type 2 or non-insulin dependent, we really do not know what is the genetic locus here. Okay. Regarding the age at onset, type 1 diabetes occurs in younger people, whereas type 2 diabetes occurs in older people. But this is again not true every time. Sometimes even the type 2 diabetes develops in children. Sometimes the people who are younger than 40 also, if they are excessively obese, because obesity is associated with type 2 diabetes. Regarding the habitus, they are normal to wasted and they are obese. Now see there, they are usually wasted, means they are very lean and thin in type 1 diabetes. Without insulin, okay, our body will develop catabolic state. Catabolic state means, we are not synthesizing a lot of important things. So there will be severe weight loss. Whereas in type 2 diabetes, okay, insulin is still there. It is still secreted by the beta cells. So insulin is still doing its job there, though insulin is getting resistant in the periphery. That is a special problem in type 2. And the opposite thing is also true. Obesity or obese people have a higher chance of development of type 2 diabetes. Now, regarding the plasma insulin, it is low to absent in type 1 and it is normal to high in type 2. Normal to high. Okay, sometimes it is high also. The beta cells are producing excessive amount of insulin, but because of the resistance in the peripheral circulation or peripheral receptor, that insulin cannot act. Plasma glucagon level is high and suppressible, whereas it is high and resistance in case of type 2 diabetes. Now, glucagon is the antagonist hormone for insulin. Whenever there is, higher blood sugar level because of lack of insulin, glucagon level is usually high. And that glucagon is making that blood sugar high. You understand like that. So in both conditions, the glucagon level is high. Now, acute complication regarding, type 1 diabetes is diabetic ketoacidosis because there is no insulin here. Whereas in type 2 diabetes, ketoacidosis doesn't develop. It may develop later on when beta cells are completely damaged or destroyed. That point is there, but that is very, very rare. It is not common at all. Rather than that, that person may develop hyperosmolar coma. In this condition, very high blood sugar level is there and there is severe dehydration. Regarding the insulin therapy, the type 1 diabetes is responsive and type 2 is also responsive. okay, usually, but it depends. If the peripheral receptors are very much resistant, then whatever insulin we give, it may not act also. But usually it is responsive. And in very late stage or condition of type 2, insulin is given for the treatment. Now, sulfonylurea are called oral, okay, anti-diabetic drug or oral hypoglycemic drug. So in type 1, there is no use of sulfonylurea. Why? Why it is of no use in type 1 diabetes? Anybody? Who can answer this?
Sir, because sulfonylurea is increase the uptake of the potassium, which increase the production of the insulin. And in type 1, there is autoimmune disease which directly destroy the beta cells. That's why we don't use sulfonylurea.
Very good answer. Excellent. Very good. So you should know the mechanism of action of sulfonylurea there. And he's right. Sulfonylurea secretes more insulin from the beta cell. Okay. They act in that, their own receptor, which are known as sulfonylurea receptor, then block the potassium channel, which leads to, depolarization of the membrane, and then calcium will enter inside, and that will lead to secretion of insulin. So they secrete the insulin. But in type 1 diabetes, the insulin producing cells are already destroyed. So what's the use of this sulfonylurea there? Okay, so we do not use, and even if we use, it is unresponsive, it is a waste. But in type 2, it is a very important drug because beta cells are still functioning. They are still secreting insulin. When we stimulate them, they will secrete more insulin. So sulfonylureas are very commonly used there. Okay, so these are some of the differences between type 1 and type 2 diabetes. Let's talk about the management of this overt diabetes, and then we'll move on to the gestational diabetes, which is the main topic. See there. So how we do that? Monitoring of blood glucose and ketones during pregnancy is one of the important management. And how we do that? We give insulin to those ladies. Especially if they are diabetic, the drug of choice during the management in case of pregnant condition is insulin. So women with insulin treated diabetes should be advised to test blood glucose level before going to bed at night during pregnancy. Why is that? That is the question. Why we should check for blood sugar level before they go to bed when they are treated with insulin? What is the answer? What is the uh, side effect of insulin therapy? What can happen?
Hypoglycemia, sir.
Exactly. Hypoglycemia. Or you can also answer in another way. If the dose of the insulin is not that much, or if it is a lesser dosage of insulin which the lady is receiving, then blood sugar level may still be higher. Okay, the sugar level is still in the range of hyperglycemia. So if we do not check it, then we do not know what is happening. So these two answers are very confidently given here. Women with type 1 diabetes who are pregnant should be offered ketone testing strip and advised to test for ketonuria or ketonemia if they become hyperglycemic or unwell, just to rule out whether this is a case of diabetic ketoacidosis or not. Because there is a high chance of development of diabetic ketoacidosis in type 1 diabetes. There are some precipitating factor. One of that is infection. Another is a state like pregnancy itself is a precipitating factor. What I'm saying here, listen properly. If she is a type 1 diabetes, it's a case of over diabetes, means she was already diabetic before she got pregnant. She may develop diabetic ketoacidosis as a complication. And how we diagnose it? There are three things, 3 points for the diagnosis of diabetic ketoacidosis. So let me highlight those 3 points. Number one is, okay, we should detect those ketone bodies, either in the blood, which is known as ketonemia, or in the urine, ketonuria, or in the breath also, because acetone is a gas which comes out in the breath. The second, This is a condition which is having metabolic acidosis. Metabolic acidosis. So if you confirm this metabolic acidosis by doing arterial blood gas ABG, okay, probably this is caused by this diabetic ketoacidosis. And metabolic acidosis is defined as when bicarbonate level is low and pH is definitely low. The third is, what is the third point here? What other point I need for the confirmation of diabetic ketoacidosis? Okay, this is lack of insulin. Lack of insulin. Now, how I know there is severe lack of insulin in the body? How I know that? Two things. One, blood sugar level. Exactly, blood sugar level is very high. And another thing, if you remember, it was probably discussed in your physiology, but I'm not sure. C-peptide. C-peptide. Now, this C-peptide is called connecting peptide, which is secreted if insulin is intrinsically secreted by beta cell. That means if beta cell is really secreting insulin, C-peptide is also formed. But what is happening here? Because this is a type 1 diabetes, there is no synthesis of insulin, no secretion of insulin. So C-peptide is absent. Both insulin and C-peptide both are absent. So these are the three important points for the diagnosis of diabetic ketoacidosis. A little bit more knowledge I'm providing here. Let's move on. Now, some other steps of the management of overdiabetes are to set the target ranges for blood glucose during pregnancy. And those target ranges are, see there, between fasting blood sugar between 3.5 and 5.9 millimole per liter, and 1 hour postprandial blood glucose should be below 7.8 millimole per liter during the pregnancy. So this is the target range we have. So see this? If it is safely achievable, women with diabetes should aim to keep fasting blood glucose between 3.5 and 5.9 millimole per liter, and 1 hour postprandial below 7.8. Now, this is a little bit confusing for the students because you usually study in milligram, okay, per deciliter. So how do you convert millimole per liter into milligram per liter? Okay, milligram per deciliter, sorry. So you simply multiply this by 18. Multiply by 18. Now, can you do that for me? Multiply 3.5 by 18 and multiply 5.9 by 18. How much it would be? Do it, please.
Sir, the first one is 63 gram per deciliter, and the second one is, sir, 106.2 gram per deciliter.
Very good. So let me write it for you. Then it will be clear to you. 63, right? 2.
Yes,
what is
sir.
The upper range? 5.9. How much you got?
106.2 gram per deciliter, sir.
Fine. We say it 106. Okay, good. 106 milligram per deciliter. And can you do the other one? Just multiply 7.8 by 18. How much it would be?
140.4.
140.
140.
Yes,
right? Okay. Let's say 140. Okay. Now see this. Now this will give you a clear picture. So fasting blood sugar should be in between this range, and postprandial blood sugar should be below this range. This is the target range, okay, in case of pregnancy. When we are treating them with medicine. This is not for the confirmation of the diagnosis. Remember that. When we are treating with insulin, this is the target range we should set. Now, the drug is of course insulin. There's no doubt. Insulin is the drug of choice. Type 2 patient on oral hypoglycemic agent should be started on insulin before the conception or before they become pregnant. And oral hypoglycemic therapy should be stopped once, okay, they are pregnant or they are suspected or they prepare to get pregnant. And women with insulin treated diabetes should be advised of the risk of hypoglycemia. Always counsel them for this risk. because hypoglycemia is a serious problem. Okay, it is a serious problem for the mother as well as for the baby. Hypoglycemia is always considered more serious than hyperglycemia over the short term, but over the long term, okay, hypoglycemia cannot remain for the long term. There will be a lot of complication development. The lady may, become comatose, okay, may become comatose, and there is a chance of death also if it is not, reverse in time. Whereas hyperglycemia, there will be a lot of long-term complication developed. So if your teacher asks you between the cases of hypoglycemia and hyperglycemia, which is the one you should, manage first, my answer is always hypoglycemia, because it produces some quick type of complication. Let's move on. Now, let's talk about some other steps in the management. We have to give folic acid also. Now, this folic acid is given just for other cases of pregnancy. Okay, just for other cases of the pregnancy. Every, pregnant lady should receive folic acid these days. That is one explanation you can give here. And being this is a case of diabetes, another explanation should be added. In diabetes mellitus, there is high chance of, complication development in the baby. One of that is a neural tube defect. Diabetes mellitus, is a like let me explain in another way. In diabetes, when there is organogenesis going on, because of this high blood sugar level, there may not be proper organogenesis. Okay, so a lot of congenital anomaly can occur during diabetes. Now, on top of that, if that lady becomes deficient in folic acid also, then there is, exponential increase in the risk of neural tube defect. So that is the one more reason we can add there. Retinal assessment during pregnancy should be done all the time. Now, see this? Retinal assessment during pregnancy, because diabetic retinopathy may develop. Diabetic retinopathy is the damage of retina because of diabetes, and that has to be diagnosed by retinal assessment. So pregnant women with pre-existing diabetes should be offered retinal assessment following their first antenatal clinic and again at 28 weeks if the first assessment is normal. If any diabetic retinopathy is present, an additional retinal assessment should be performed at 16 to 20 weeks. And it should not be considered a contraindication to vaginal birth. So whatever has happened, already happened. So we don't need to change the steps of the management of that pregnancy or labor, but we have to go for the proper treatment and proper counseling. Now, can anybody tell me what is the treatment of diabetic retinopathy? What should we do? Maybe you have studied somewhere, or maybe you have heard. Anyone?
Photocoagulation.
Excellent. Very good. Yes, please go on. Yeah.
Sir, basically, sir, we can go for laser treatment, sir, because, sir, there is the formation of the new blood vessel at the back of the retina, sir, in this retinopathy sort of case. So we can treat it with laser treatment, sir, mainly. Exactly.
Okay. Irfan was also saying the same thing. It's called photocoagulation or laser photocoagulation. You have, that's the correct answer. And the second is tight control of blood sugar level. Don't forget that. Why there is a complication? Because the blood sugar was not properly or tightly controlled. Let's do that. And probably we can postpone all the complications or long-term complication of diabetes. Let's move on. Now, another part of the management is renal assessment during pregnancy, because diabetic nephropathy may develop. Diabetic nephropathy. So we have to go for renal assessment. And there are so many different ways of doing renal assessment. One, routine urine analysis. Another is renal function test. What is the serum creatinine level? What is urea level? Okay. What is a albumin excretion rate in the urine? So all these things are there. So see this, if serum creatinine is abnormal, that is 120 micromole per liter or even more than that, or if total protein excretion exceeds 2 grams per day, referral to nephrologist should be considered. This is a serious case already. The kidneys have been damaged by the complications of diabetes. So we should manage appropriately. Screening for congenital malformations. I already talked about this. There are so many different types of congenital malformation. Neural tube defect, congenital heart disease, okay, something known as microcolon syndrome, okay, caudal regression syndrome. So different things are there. So we must monitor or screen for congenital malformation. That can be done by ultrasound or some other test. Monitor fetal growth and well-being. Okay, so we all know how to do it. One is by ultrasound again. And usually there are two things which I like to highlight here. One, if this is a case of overt diabetes mellitus, it depends how long she has been diabetic. If already the complications of diabetes are developed, the baby will become IUGR baby, okay, intrauterine growth retardation baby. So the baby is born very small. Whereas if the diabetes is recently diagnosed, okay, not very long-term diabetic, or the complications have not yet developed there, then, and again in gestational diabetes, there is high chance of macrosomic baby or big baby. So never forget these two explanations. Both are correct, depends on the situation. Okay, so diabetes mellitus during pregnancy can either have IUGR or can have macrosomic baby. But if the examiner asks which one is more common, your answer is straightforward here. Gestational diabetes is 90% among the diabetes mellitus during pregnancy. So macrosomic baby chances are much higher than IUGR baby. Okay, let's move on. Now, what's the timing and mode of the birth? When should we, plan for the delivery? Pregnant women with diabetes who have a normally grown fetus should be offered elective birth through induction of labor or by elective cesarean section if indicated after 38 completed weeks. Means after she is a term pregnancy. Then, okay, we don't wait any longer after that. We don't wait for 40 or 41 weeks. You induce the labor. And how to induce the labor? Small question again. How to induce the labor?
Sir, IV oxytocin should be.
Oxytocin through
IV oxytocin.
prostaglandins.
Very good.
Mifepristone.
Very good. Very good. So prostaglandins and oxytocin. These are two excellent answers. Oxytocin and prostaglandin. Oxytocin is used for augmentation of the liver also and to induce the liver as well. Whereas prostaglandins are the very important drug which induce the liver. Apart from them, if your examiner still waiting for the answers to be completed, you can call artificial rupture of membrane or amniotomy as another answer. Balloon dilatation of the cervix as another answer also. Okay. So if those two are told in the beginning, probably they don't want to listen anymore. So those are the appropriate ones. Pregnant women with diabetes who have an ultrasound diagnosed macrosomic fetus, cesarean section is indicated. Why we don't try for the vaginal delivery if the baby is big? What's the risk?
Sir, maybe there is a risk of injury to the baby because there is a diameter of the pelvic is not more than the baby head. That's why we prefer the cesarean section.
Very good answer. Very good. One more. Anybody else?
Basically, the same point. So you have the same point because when there is a macrosomic baby, so sir, that baby said he cannot just pass the pelvic diameter. Like sir, there will be no engagement of the baby with the pelvic diameter. You've got cesarean section.
Good. So all of you are answering in the same way. Okay, there is a high chance of cephalopelvic disproportion. Very good. This is called CPD. The explanation you are giving is CPD itself, cephalopelvic disproportion. The size of the head, okay, the size of the baby is too big in comparison to the diameter of the pelvic cavity. That is one. Okay. And the most important cause. Another one, there is high chance of shoulder dystocia in case of big baby. Shoulder dystocia means the head is delivered, but the shoulders are not delivered properly. It's stuck of the shoulder there. Okay, so all these things are there. Let's move on. Now with this, let us enter into the topic of gestational diabetes. What is the definition first? Gestational diabetes mellitus is defined as carbohydrate intolerance of variable severity with onset or first recognition during pregnancy. Before she is pregnant, there should not be any hyperglycemia evidence. Okay, otherwise it will be overt diabetes, not gestational one. This diabetes has to be started right, in this pregnancy. Undoubtedly, some women with gestational diabetes have previously unrecognized overt diabetes. That is, very well understood, isn't it? Because to diagnose overt diabetes, they should go for investigation. They should have some sign and symptom. And sometimes, if they are not there, okay, maybe the asymptomatic glucose intolerance, then we cannot pick it up and we simply take it as a gestational diabetes. But actually, it is a case of overt one. Usually, it affects in second and third trimester, and some will remain diabetic even after the delivery of the fetus, while others will revert to the apparent normality. Majority of them will revert to the normal one, and some ladies still remain diabetic after the delivery of the fetus. So this is what happens after gestational diabetes, and it usually occur in second or third trimester. Now, what is the pathophysiology? Let's talk about it. Regarding the pathophysiology of gestational diabetes, this disorder is induced by pregnancy. There's no doubt about it. But what inside the pregnancy? What is doing it? Okay, we are going to talk about that. Perhaps due to exaggerated physiological changes in glucose metabolism. Pregnancy is already a diabetogenic state. It's already a diabetogenic state. What does that mean? What does that mean? Pregnancy is a hyperglycemic condition. Now, even though the lady is not, not fallen into the definition of glucose intolerance or diabetes, but the level of blood sugar may be at the higher range than the normal. Higher range than the normal. That's why it is known as a diabetogenic state. Okay. Now, one small question I like to ask you here regarding the different hormones. Which hormones, okay, are the counter-regulatory hormone of insulin? In other words, those hormones cause hyperglycemia. What are those? Yes, which are those hormones?
Glucagon and human
Good.
placenta lactogen,
Good.
corticosteroids.
Good. Good. Anybody else? Can you add one or two there? Yes.
Sir, I will go with mainly, sir.
Okay. Now, absolutely correct. The names which he was taking are absolutely correct. The first is glucagon. Okay, glucagon. The another one is growth hormone. Let me talk general thing first, and then I'll come to the gestational diabetes. Third one, okay, cortisol. Okay, cortisol. The fourth one is adrenaline or noradrenaline, and fifth is a thyroid hormone. All of them raises the blood sugar level, and insulin is the only hormone which decreases blood sugar level. So that's why glucagon, growth hormone, cortisol, adrenaline and noradrenaline, and thyroid hormone are called counter-regulatory hormone of insulin. They cause hyperglycemia. Now let's come to the pregnant condition or pregnancy. In pregnancy, the human placental lactose is one of the very important, substance, okay, or the hormone you can say, which is secreted by placenta. This HPL is mainly responsible for the diabetogenic state in case of pregnancy. We'll talk about that, okay? And other hormones also play the role. It is unclear why some ladies are unable to balance the insulin need and develop gestational diabetes mellitus. So it is not very clear, okay? Why some ladies can, balance the things up and why others cannot. An alternative explanation is that gestational diabetes is a maturity onset or type 2 diabetes unmarked or discovered during pregnancy. So they are already at risk of developing diabetes, but because of the pregnancy, it just become apparent. That may be one of the alternative explanation. Now, see this. What are the physiological changes in glucose metabolism during pregnancy? What is really happening? Why this is called the diabetogenic state? Okay, what is the effect of pregnancy over glucose metabolism? See this? So pregnancy is a diabetogenic state for the following reason. One is human placental lactose. We have just talked about this. It has got anti-insulin and lipolytic effect. Lipolytic means it breaks down lipid, okay, or it break down fat. And by doing that, it is making free fatty acid available everywhere. It increases the glucose level in maternal plasma and thus makes more glucose available to the fetus. So that is a very important job of this HPL actually, because baby needs glucose all the time, But when human placental lactose is excessive, then it may cause a diabetogenic state in the mother. Steroid hormones have an anti-insulin effect. We just now talked about them, like different types of corticosteroid and even progesterone. They all are steroid hormone. And pregnancy is a stressful condition, a stressful situation. So there is excessive cortisol as well. Some insulin may be destroyed by the placenta, and that may help the process. Now, one small thing, can insulin cross the placenta and go towards the baby or not? Yes, can it go towards the baby or not? The insulin from the mother, can it go to the baby by crossing the placenta?
No,
No,
sir.
sir. No, sir, it cannot cross the placenta.
Exactly. The answer is no. It cannot cross the placenta. Okay. And don't worry about the development of fetal hypoglycemia by the maternal insulin because it cannot cross. The reason for hypoglycemia in the baby after the birth is somewhat different. We'll talk about that a bit later. Now, let's come to the slide. The diabetogenic effect of pregnancy are increased by maternal obesity and repeated pregnancy. If the mother is obese, if the BMI is more than 30 already, okay, and because of repeated pregnancy, then the diabetogenic effect are just increased. Glycosuria is more common during pregnancy due to a lower renal threshold for glucose excretion. So I want a little bit, I want to give more explanation here because this is a very interesting, part of the discussion. Now just listen. Some of us, okay, for example, okay, the number of students who are listening to my lecture right now and myself, if we go to the lab and give our urine for the examination, and that test is a glucose availability in the urine, or what is the presence of glucose in the urine. Some of us may simply have presence of glucose, especially if we do that test after the taking meal, after 1 to 2 hours of taking meal. Now, why? Because some of us may be having decreased renal threshold for glucose excretion. Normally, this is about 180 milligram. 180 milligram is the average one. So what does that mean? If the blood sugar level is 180 milligram, okay, then it may simply cross the renal threshold and then the glucose is excreted in the urine. But sometimes even at the range of 150, it may be seen. 150, sometimes 140. This is known as decreased renal threshold for glucose excretion. And pregnancy is one of the condition where there is lower renal threshold for glucose excretion. So don't be surprised if that pregnant lady is having presence of glucose in the urine even without diabetes. Let's move on.
Sir, I have
Yes, yes, please. Yes, I cannot hear you properly. Yes, say it again.
is a diabetic state, and human placental lactogen also cause lipolytic effect, and diabetic state also increase the production of free fatty acid. If sir these free fatty acid uh, we can transfer the placenta and enter into the maternal circulation, and it lead to the adiposity. And how we can sir handle this situation?
Okay, now let me explain it from the beginning here. This lipolytic effect, how it contributes to the mechanism of diabetes. Now listen here, these free fatty acid which are formed because of this lipolytic effect of human placental lactogen, they cause insulin resistance in the periphery. They are very important factor for the development of insulin resistance. Never forget this. That's why this gestational diabetes is considered a type or part of type 2 diabetes. It is a part or form of type 2 diabetes. Okay. So this is another reason we can add here.
Excuse me, sir.
Yes, yes.
Sir, just adding to the point of Irfan, like sir, we know that sir, like the human placental lactogen, like sir, it like sir gives us an anti-insulin sort of a function. Like sir, one is the like sir, it utilizes the free fatty acid. But sir, another point is that it promotes the nitrogen retention, which also helps. So sir, please can you give a little bit about this nitrogen retention?
No, this nitrogen retention doesn't have important role here. We are talking about diabetes for the time being, okay?
Yes.
And my explanation here is how this human placental lactogen is responsible for the diabetogenic state. That's it. So I gave two explanations for you here. One, it is anti-insulin itself, so that's why it increases the blood sugar level. And another one, because of its lipolytic effect, this free fatty acid may cause insulin resistance. Okay. So
Yes,
let me move further. Now, what are the effect of pregnancy on this diabetes mellitus? So what is happening? See this. It increases the requirement for insulin doses. So pregnancy causes insulin resistant state. That's what I just explained to you. So that's why it is considered as a type or part of type 2 diabetes. And type 2 diabetes is all about insulin resistance. So what is the meaning here? We may need to give more amount of insulin to control the gestational diabetes. Another one, there is a risk of deterioration of nephropathy and retinopathy. If she is already having chronic diabetes or overt diabetes, because of this pregnant state or condition, okay, the nephropathy and retinopathy risk is even further increase because of the hyperglycemic condition. That's it. The hyperglycemia was already there from the beginning. On top of that, because of this diabetogenic state, okay, this pregnancy state or condition, the risk is further increased. That's why time and again we need to examine for nephropathy or retinopathy. And third one, there may be the chance of diabetic ketoacidosis, especially if she is already having type 1 type of diabetes. So this slide is all about what is the effect of pregnancy on overt diabetes. Okay, overt diabetes means she's already having diabetes before she is pregnant. So what is the further effect of pregnancy on that diabetes? So this is the explanation. Now, what are the maternal complications of maternal effect because of diabetes? Let's talk about it. There is increased risk of abortion. There is increased risk of preeclampsia. There is increased risk of infection like vaginal candidiasis, UTI, endometrial or wound infection. Means there is more chance of infection everywhere. These are the different example here. Candidiasis is a fungal infection. UTI is caused by E. coli and other coliform type of bacteria. Endometrial or wound infection can caused by any of the other organism. Polyhydramnios, preterm delivery, prolonged labor due to big baby. There is increased chance of PPH or postpartum hemorrhage as a result of over distension of the uterus. And there is increased chance of lower segment cesarean section rate also. LSCS is lower segment cesarean section. So let me clarify a little bit about this because these are the important points for you. The risk of abortion and preeclampsia is definitely increased as a result of diabetes. Okay, more so in case of chronic diabetes. They are increasing chronic diabetes. Increased risk of infection, no need of an explanation here. Polyhydramnios is excessive collection of the amniotic fluid. Amniotic fluid index is calculated because of ultrasound, and that is usually more than 25. Preterm delivery, there is a chance. Okay, and one more thing I like to add here: if this baby is born preterm, there is more chance of development of respiratory distress than other types of preterm baby. Now, why respiratory distress is developed in the preterm baby? What is the reason?
Surfactant
Yes.
is not produced, that's why.
So the surfactant which is
And
produced by
lungs
type
is
2 pneumocyte,
premature.
the surfactant is not produced. And so the surfactant is produced about after the 32 week of gestation. So basically the surfactant is not produced, causing that respiratory distress.
Exactly. Yeah, absolutely correct. So that's the point I like to hear here. Remember, in preterm baby, when they are prior to 34 weeks, means if they are delivered prior to 34 weeks of gestation, there is no synthesis of surfactant. So we already know that. But in this case, the mother is diabetes here. Okay. If the baby is delivered prior to 34 weeks, there is even more risk. Okay, even more risk. Or one more sentence I like to add here, even after 34 weeks, right? 34, 35 weeks, something like that, or lesser than 36, the chances of respiratory distress is still there because in the presence of excessive blood sugar level, the surfactant may not function properly there. So these are the explanations given in some of the textbook. Prolonged labor due to big baby. This is a macrosomic baby. The baby is more than 4 kg. So difficult to deliver. So even if you try, vaginal delivery, definitely there is a chance of prolonged labor. And vacuum delivery may fail. Forceps delivery may fail if you try. So the ideal way of delivering this type of babies are cesarean section. There is no doubt about it. But prior diagnosis has to be made. Because of over distension of the uterus as a result of big baby again, there is more chance of postpartum hemorrhage. This is known as uterine atonia. Atonia of the uterus. The uterus cannot contract properly because of over distensibility. Polyhydramnios is also helping in this process. And lastly, there is increased LSCS rate. The lower segment cesarean section rate is absolutely increased in case of diabetes. Of course, we have to go for this. There's no harm of taking the lady for lower segment cesarean section here. This is the way of delivering. But having said that, this is a type of surgery. And surgery has always more risk than giving a vaginal delivery. Okay, who knows? There may be excessive bleeding during the surgery and the lady may die. Okay, that thing is always there. But having said that, the risk is very, very low. In a good hand, there is a 100% success rate of low segment cesarean section. But that small amount of fear is always there. So these are some of the maternal effects of diabetes mellitus on pregnancy. What are the fetal complications? Okay, if the mother is diabetic, or if diabetes mellitus develops during pregnancy. So this is a combination of the discussion regarding both overt diabetes as well as gestational diabetes. There is increased chance of abortion, we already talked about. Increased chance of abortion, and abortion is a termination of pregnancy prior to 20 weeks of gestation. There is unexplained, intrauterine fetal death. This is quite common in, diabetes mellitus, unexplained IUFD. Prematurity and IUGR, okay? In IUGR is especially more common in case of chronic or overt diabetes as a result of a lot of complication. This congenital anomaly point is the one which is asked to the student. Now, see this: cardiovascular, nervous system, caudal regression syndrome, and some others anomalies are there which may have a chance to develop. The cardiovascular are the most common, like ventricular septal defect and transposition of the great vessels, a transposition of great artery called TGA. They are quite common. But other, congenital heart disease can also occur. Okay, so many are there. Some are acyanotic, some are cyanotic. Regarding the nervous system anomaly, this is the second most common, like open neural tube defect, which is anencephaly, or sometimes even there is microcephaly. Microcephaly means small size head as a result of small size brain. Caudal regression syndrome, also known as sacral agenesis, it is very specific to gestational diabetes mellitus. That means the lower part of the body is not properly formed. Okay, the lower part of the body is not properly formed. This is called caudal regression syndrome. And another one is also mentioned, like microcolon or anal atresia. In some of the textbook, it is clearly written as a microcolon. The diameter of the colon is small, and that baby has a high chance of developing constipation from very early time of the birth. Renal agenesis can also be there, no development of the kidney. Now, what happens if there is no development of the kidney? What happens to the baby? Yes, what problem will occur to the baby if there is no development of the kidney? Who can answer this?
Sir,
Yes. Can the baby survive if both kidneys are absent?
No, sir.
Exactly. Okay, this is incompatible to life. Incompatible to life. But if only one kidney is absent, then the baby can still survive. But there is some problem now. The volume of amniotic fluid may be less than the required. Okay, and as a result of this, the lungs may not be developed properly. This is known as pulmonary hypoplasia. This is definitely more common if both kidneys are absent, but sometimes it can also happen if only one kidney may be absent. Okay, so these are some of the questions which may be asked to you. Now, another type of important fetal complication is macrosomia. This macrosomia is the effect, okay, is the effect of diabetes. Now, let me explain why the baby is big here. The reason is quite easy. Just listen properly. Because of the excessive level of glucose all the time in the maternal circulation, that glucose is passing to the fetal circulation through the placenta. Only insulin cannot cross, but glucose can easily cross it. Okay, so the fetus is having excessive amount of glucose. Now that glucose will stimulate the release of insulin. So baby is having more amount of insulin also in the blood. Insulin is a type of anabolic hormone. It synthesizes everything. It converts glucose into glycogen. Okay, it synthesizes lipid or fat, and it helps in the protein synthesis as well. So because of this hyperinsulinemia, the baby becomes macrosomic. This is the explanation. So it depends how big, we cannot pinpoint. It is not all the time it is more than 4.5 kg or 4 kg. Sometimes it may be just on the higher side of the normal. So it is always confirmed by ultrasound. So brain is not affected in case of macrosomic baby. That's a good point. Another important complication is shoulder dystocia. Now, the meaning of shoulder dystocia is after the head is delivered, the shoulder got stuck there. Okay, they are not rotating, especially the anterior shoulder got stuck just behind the pubis symphysis. So shoulder dystocia is quite common because the larger diameter, that is the reason. Let's move on. Now, after the birth of the baby, what may be the effect of diabetes mellitus? Effects on the neonate. Now, one is respiratory distress syndrome, especially if the baby is born premature or between 34 to 36 weeks of the gestation. Hypoglycemia is a very important complication. Hypoglycemia. Now, how you explain there is hypoglycemia in the baby? Anybody? I'll give a chance to some of the students here. Why hypoglycemia is common? Sure.
But basically, sir, in the baby, there is a higher level of the insulin. And so, due to which this insulin, sir, it will cause that hypoglycemic effect here in the baby, sir.
Exactly, exactly. And why? Why the baby is not hypoglycemic before the delivery? Why is that?
Because due to the maternal glucose.
The barrier, sir, because the glucose is passing the placental barrier from the mother to the baby.
Exactly. Okay, I already got the answer here because glucose can easily cross the placenta and glucose is constantly supplied in the baby. So let me explain this from the beginning. This is a very important question when we talk neonatology. In the next semester, neonatology is a big part of pediatrics, and infant of diabetic mother is, discussed there also. If you know the concept right here, it will be very easy for you. So the question here is why there is high chance of hypoglycemia development after the birth if the mother is having diabetes mellitus, and the answer is because inside the uterus or before the birth, the glucose is easily crossing the placenta. There is fetal hyperglycemia. That fetal hyperglycemia is inducing the release of excessive insulin. So the baby is in the state of hyperinsulinemia. But that excessive insulin is balanced up by the excessive glucose. So there is no problem before the birth. But after the birth, that constant supply of the glucose is cut off. Okay, it is cut off. This point has to be included here. On top of that, there is excessive insulin. So that insulin will quickly, cause entry of glucose inside the cell, resulting in severe hypoglycemia to the newborn. So to prevent from this hypoglycemia, we need to feed the baby quickly. Okay, within half an hour of the birth, we need to give feeding to the baby, and constant feeding is necessary after that. And we have to screen the blood sugar level. And if you suspect the baby is having hypoglycemia, quickly go for the treatment. The treatment is very easy. You just supply the glucose there. You start the glucose drip in the baby. Another important, effect is hypocalcemia. Hypocalcemia. This hypocalcemia is decreased calcium level. Okay, there are so many different mechanisms for this. One is given in your textbook that the parathyroid gland is not functioning properly. The parathyroid gland. And which hormone comes from parathyroid gland? Which hormone?
So the parathormone
So why? What is the what is the relation of parathyroid hormone and hypocalcemia? I'm sure every student know this because we have talked about this maybe before. See this, isn't
The
it?
thyroid gland, the calcitonin is released.
No. Calcitonin comes from the thyroid gland. Don't mix the things here. Calcitonin comes from thyroid gland. Okay. Parathyroid glands secrete parathyroid hormone or parathormone. Now, when parathyroid hormone is not, properly secreted, there is a chance of hypocalcemia. Just understand like that, because parathyroid gland, parathyroid hormone will increase the level of calcium in the blood. If that is not, happening, then hypocalcemia commonly results. Polycythemia. Polycythemia is very common in the neonate who is born for diabetes mellitus mother. Polycythemia is excessive RBC mass. Okay, there are lots of reasons behind it. One of the important reason is there is intrauterine hypoxia. Intrauterine hypoxia. Okay, especially in case of chronic type of diabetes. That is quite common because chronic diabetes results in IUGR. IUGR babies are usually hypoxic inside the uterus. Hypoxia results in increased erythropoietin, and that is making a lot of RBC synthesis. So easy type of explanation. Even if the baby is big, the big baby has an increased amount of everything. Okay, you understand like that. The blood volume is also high. The blood cells are also high. The baby look very red at the time of birth. It is called shoddy and red appearance. So these are the different explanation for polycythemia. And birth trauma, no need of any explanation here. It is very easy because the big size, there may be trauma during the delivery. More common during the vaginal delivery, definitely, than during cesarean section. Now, there is an explanation which every student know it already, but still it is such an important one. So it is repeated. Maternal hyperglycemia will cause fetal hyperglycemia. Fetus means before the time of birth. Remember, the baby is still inside the uterus. This fetal hyperglycemia is inducing the pancreatic beta cell hyperplasia. So there's a lot of insulin release. Fetal hyperinsulinemia. This fetal hyperinsulinemia is responsible for macrosomia, organomegaly, polycythemia, hypoglycemia, and RDS. Now, some of them develop before the delivery, some of them develop after the delivery. Especially this hypoglycemia develops only after the delivery because before the delivery, there is constant supply of glucose from the maternal side. So hypoglycemia will not result. Now, let's talk about the screening test we should do for the diagnosis of this condition. Now, we do not do this screening test for all type of ladies, okay, especially if they are having certain risk factor for the development of gestational diabetes, then they are increasingly done. So what are the risk factors? Let's talk about them now. See this? The age, okay, the age more than 25 years is one. The body mass index above 30. So this is the definition of obesity. Everyone know obesity is always an important risk factor for type 2 diabetes development or gestational diabetes development. Previous macrosomic baby weighing 4.5 kg or above. So this is a very important risk factor. Who knows? The lady is having over diabetes, which was not diagnosed, so something like that. So this is a very important history we should take. Just simply ask how many babies you have, which gravida is this, which parity is this, and if she said, I already have 1 or 2 babies before, then ask about the birth weight. That's it. Previous history of gestational diabetes has a more chance of occurring in this pregnancy also. Family history of diabetes, like first degree relatives with the history of diabetes, and family origin with the high prevalence of diabetes, like the ladies who are from South Asia, okay, from the Caribbean, especially the black female, and the persons, the ladies who are from Middle East, okay, Middle East country. So there is a higher chances of having diabetes. This is simply because of the racial difference. And we belong from South Asia, we all know that. Okay, not all, some of my students are from African countries also, but I'm talking about the majority of the students, Pakistani students, they are from South Asian country. Okay, so there is a high prevalence of diabetes from our part of the world. Now, what is this screening test? This is the glucose challenge test. Okay, glucose challenge test, which is done around 24 to 28 weeks. This is the second trimester. So plasma glucose is measured 1 hour after a 50-gram glucose load without regard to the time of day or time of last meal. So we are going to give this, okay, 50 gram glucose to the lady, and then, okay, after 1 hour of that, we are measuring the blood sugar level. A value of 140 milligram per deciliter or higher, okay, will identify 80% of all women with gestational diabetes. Now, so see this is a very important data. Will identify 80% of all women with gestational diabetes if the value is 140 milligram per deciliter or higher. Value less than 140, the further test is not required. We give them clean certificate. And a value of more than 200, okay, value of more than 200, confirm the gestational diabetes and no further test required. So I want to clarify this, okay. So sometimes there may be a mistake, so simply multiply this by 18, and if the calculation is correct, then you think it is the correct one. Otherwise, please correct it, okay. Now see this, because 7.8 is written here and here also. You can quickly do it right now. Can you divide this 200 by 7.8? How much it would be? So let me find out which is the correct out of these two. Anybody? Quickly do it.
$25.64.
35.64, yes, sir.
Okay. Okay. Now see this. So the first one is the correct. Here it should be around 11, if I'm not wrong. Can you divide 200 by 18? How much it would be? 200 by 18. Can you divide it?
11.11.
11.11.
Exactly. So please correct it. This has to be 11.11 here. Okay. This is not 7.8. Let's move on. Now the confirmatory test is done by oral glucose tolerance test, or OGTT. What is this? This is done with 100 gram of sugar, and the recommended things are patient with abnormal challenge test, just like what we discussed just now, will be those ladies are fit for this type of test. Understand like that. First we always go for that, and then for the confirmation we go for oral glucose tolerance test with 100 gram of glucose. So this is American College of Obstetrics and Gynecology recommendation, ACOG. American College of Obstetrics and Gynecology recommendation. This is done with 100 gram glucose. But according to World Health Organization, WHO, we may use 75 gram glucose in this place also. Okay, so it doesn't matter for us. Both can be done. So WHO is also a parent institution or organization all over the world, and ACOG, okay, has given so many guidelines for us. So what are the results? Fasting, the upper limit is 95 milligram, 1 hour 180, 2 hour, okay, 155, in 3 hour 140. So it's gradually decreasing. See this, okay. 1 hour is the maximum, 180. So gestational diabetes is diagnosed when any two values are met or exceeded. So this is how you confirm it. And these are done in the fasting and after 2 hours like this. Now, finally, how to manage it. So let me, do this and stop today's discussion. Diet and exercise are the important part of the management, because this is a case of diabetes. So we should, control too much carbohydrate diet, especially the sweet type of food should be cut off, and exercise should be promoted. Nutritional counseling is a cornerstone in the management of diabetes. The goals of such therapy are to provide the necessary nutrients for the mother and fetus, to control the glucose level, and to prevent the starvation ketosis or starvation ketoacidosis. So these are the goals of such therapy. So a diet plan is made and provided to the mother. That is the best we can do. What she should eat, in the breakfast, in the lunch, in the dinner. What is the total calorie she has to take, because this is a pregnant state. You should not decrease the amount of calorie to her also, because the baby is developing in her. So all these things are very important. a liberal exercise program is encouraged. Now, let me explain a little bit here. Exercise really helps the control of hyperglycemia. Why? There is a reason. During exercise, okay, a lot of glucose, whatever is present in the blood, will enter inside the muscle cell, and that doesn't need insulin. This entry is free of insulin during the exercise. But when we are having rest or not doing enough exercise, the same entry of glucose inside the muscle or the fatty tissue needs insulin. So this is a very important concept here. So any type of diabetic patient, not only in pregnancy, any type, exercise plays a big role in the control of diabetes, and diet, there's no doubt about it. What are the hypoglycemic therapy? Okay, we are talking about pregnancy, so we should focus our discussion here. Hypoglycemic therapy should be considered for women with gestational diabetes if diet and exercise fail to maintain the blood glucose target during a period of 1 to 2 weeks. So in the beginning, we try diet and exercise therapy, and if later on, if that fails, we definitely need to go for the treatment. If fasting blood sugar is more than 105 and 2-hour postprandial is more than 120, even after initiation of dietary regulation, we need to go for it. It should be considered for women with gestational diabetes if ultrasound investigation suggests incipient fetal macrosomia. So see that? That's what I was talking before. Ultrasound will definitely pick how big is the baby. Okay, so if it is, bigger than what we expect, then we need to go for the treatment. Now, the drug of choice for hypoglycemic therapy is insulin. This is insulin. And you already know insulin is the drug of choice of treatment of diabetes during pregnancy. Now, see this, insulins are of different type. The regular insulin, okay, and then very fast acting insulin, very fast acting like Aspart and Lispro. These are the two important examples. Some insulins are intermediate acting and some are long acting insulin also. But regarding the management of diabetes in pregnancy, we go for the regular, rapidly acting or fast acting insulin. Now, another important question. What is the role of oral hypoglycemic agent during pregnancy? Your answer is, as far as possible, we don't go for it. Okay, we go for insulin. But sometimes, some of the people or some patient may opt against the insulin because insulin is an injection. Insulin is an injection. You should inject it in the subcutaneous area. So this is a cumbersome procedure for so many people. They don't want to do this, and they simply ask to the doctor, can you prescribe the oral drug for me? Okay, so we should know whether they are available or not. Now see here, metformin and glyburide. Okay, another name for glyburide is glibenclamide. This is a type of sulfonylurea, are safer alternatives even in case of pregnancy. But let me clarify again, they are not safer than insulin. As far as possible, we should, say, please go for insulin. This is absolutely safe for you rather than this drug. They are also safer than other option, and it is their choice. Okay, we do not force our decision on our patient. We always give them choice, and we welcome them to do the right one. Now, what are the target ranges for blood glucose during pregnancy? So see that. If it is safely achievable, women with diabetes should aim to keep fasting blood glucose between 3.5 and 5.9 millimole per liter, and 1 hour postprandial blood glucose should be below the 7.8 millimole per liter during pregnancy. So this is the target range. Now, what about the timing and mode of the birth? This is also discussed already. Okay, this is done by finding what is the weight of the baby first. If this is a macrosomic baby, if it is a big baby, and if the baby has already crossed the period of maturity, that is after 37 weeks, completed 37 week, we go for elective birth. That elective birth means we induce the labor, okay, either by oxytocin or prostaglandin, and give the birth to the vaginal route. Or if the baby is too big, if we think the risks are too much, then we go for elective cesarean section. Okay, so this is already well understood. Now, what are the other types of management? Monitor blood glucose and ketone body during pregnancy. This is a very important one. Screening for congenital malformation. We have to do it. Monitor fetal growth and well-being. This is also important one. We have already discussed this before. And if the lady has developed preterm labor and she is diabetic, so try to postpone that labor. Okay, try to postpone the labor, and that is done by using tocolytic agent like beta agonist drug. Salbutamol is the good example here. There are so many others also. Okay, so this is one of the concept, and another, you can also go for calcium channel blocker or magnesium sulfate. These are also tocolytic drug like nifedipine or magnesium sulfate. There are some other options if she develops preterm labor. But the question here is how preterm is the condition. Fine. If it is around 32 weeks, or 33 weeks, so it is very near to the 34 weeks. So definitely we are going for this, tocolytic therapy. But if she is just 28 weeks, and this is a very difficult decision to make, because a prolonged type of tocolysis is also not good. Now, another important part of this class is screening and diagnosis of congenital malformation. Okay, how we know that particular baby who is developing has a higher chance of development of congenital malformation. Now, see there, the main contributor of perinatal mortality is congenital malformation. And to repeat, what are those congenital malformation? One is neural tube defect. Another is congenital heart disease. The congenital heart disease is even more common than the neural tube defect, like anencephaly. Okay, caudal regression syndrome, microcolon, even renal agenesis. These are the different ones. The first test done to detect the congenital malformation is the level of glycosylated hemoglobin, HbA1c. Now, what is the importance of doing this HbA1c? This HbA1c will tell us what is the control of hyperglycemia in the previous 4 to 6 months or previous 3 to 6 months. Okay, so if the level of HbA1c is higher than the desirable level, that means the blood sugar level was not well controlled, and that type of pregnant lady has higher chance of development of congenital malformation in the developing fetus. So see this, perform 4 to 6 weeks after conception and reflects the periconceptional blood glucose level. That's what I told just now. Around 3 to 6 months prior, okay, to the test, what is the control of blood sugar level? HbA1c level will tell us. If the value is more than 10, the risk of malformation is about 23%. And normally, it should be less than 6.5. It should be less than that. And 10 is too high. So the chance of malformation is also very high here. Another way is doing vaginal ultrasound, which is done at 10 to 14 weeks. And at this time, this is one of the best tests. Maternal serum alpha fetoproteins can be done. Maternal serum alpha fetoproteins. Now, this alpha fetoproteins has got important implications here. And one of the condition, is a Down syndrome. Okay. Now, this is not related to pregnancy, but I'm asking this question because this is an important MCQ based question. Which tumor, has a alpha fetoprotein as its tumor marker? Which tumor? Anybody? Pathology. Yes? I'm sure you have already done the topic of neoplasia. So which cancer?
Hepatocellular
Testicular and
carcinoma.
ovarian cancer, sir. Testicular ovarian cancer. And sir, liver cancer most common, sir.
Exactly. Hepatocellular carcinoma. Hepatocellular carcinoma. Never forget this. This is a very important question. Alpha-fetoprotein is the tumor marker for hepatocellular carcinoma. Yes, and I agree with Uzer's answer also. They may be high in case of gonadal carcinoma also. Gonadal carcinoma. Now, echocardiography can be done to diagnose cardiac anomaly, and that is done at 22 to 24 weeks. Remember, this echo can identify even the fetal anomaly.